All right, guys, we were back on the gynecological emergencies. Let's talk about the specific disorders that we're going to talk about here. Had to start this one back over, so please give me a moment here. I'm going to start it from the first slide. There we go. All right. I don't know why the type, somehow the closed captioning came on. I don't know exactly how it happened. I was like, no, let's not do that. All right, so the pelvic inflammatory disease. These guys are, usually the infection of the female reproductive tract, uterus, ovaries, the vagina. Again, it usually causes abdominal pain, and it usually, again, it inflames everything. And it's usually caused by, again, sexual intercourse, sexual issues. Usually some sort of sexually transmitted disease, gonorrhea or chlamydia. And again, they will develop into, they kind of go undetected in women until the frank PID develops. So usually they've had it for a while. Usually they got a history of multiple sexual partners, or somebody that has multiple sexual partners, some sort of recent problem, or if they've had an intrauterine device, they can also get pelvic inflammatory disease. Usually the post-infection damage causes infertility, and this can either be just a simple thing, or it can actually be an ongoing thing for a while. So again, usually they will cause lesions, which usually lead to the infertility, and also can lead to ectopic pregnancies. So if you've got the lady with the ectopic pregnancy or you think that it's an ectopic pregnancy, ask them if they've ever had pelvic inflammatory disease before. All right, they usually walk with that shuffling gait. They just kind of take the little baby steps. So we call it the PID shuffle. And again, they usually fever, chills. They'll have a foul-smelling discharge, usually yellow and irregular menses is another thing. And they can actually appear kind of toxic-looking or acutely ill. Again, your treatments is an antibiotic regimen. Again, make them comfortable. Again, do not perform a vaginal exam. Repeat, do not perform a vaginal exam. Your ruptured ovarian cyst. Remember that the corpus luteum releases the egg, but then usually when the cyst ruptures, there's a small amount of blood that actually spills out into the peritoneal cavity, which causes irritation. If too much of it spills out, extremely painful. Usually they have a history of ruptured ovarian cyst, and again, it can also have some vaginal bleeding going on with that. Cystitis is usually a bladder infection. That's the nice way to say bladder infection. And it usually happens a lot with the ladies because they got a really short urethra. It's easy to get bad guys into the uterus. Not the uterus, but into the urinary bladder. And so, again, usually they got a urinary frequency. There's pain on burning. They usually might have a low-grade fever with that. Menstrual smirts. You're going to see this later. I would probably know what it is. It's usually mid-cycle pain. It's usually when ovulation occurs. Usually related to that ruptured ovarian cyst. It's just really small. And again, the treatment is just simple, symptomatic. But usually if you start timing out everything, you can probably narrow it down to menstrual smirts. Endometriosis is an infection of the uterine lining, okay? Occasional comfort, and again, procedures such as the D&C that, again, it just makes the lining irritated. It's got mild abdominal pain, foul-smelling discharge, and fever. Not to be confused with this character right here, was endometriosis. Usually this is endometrial tissue found outside of the uterus, found in the abdomen or pelvis. So bleeding causes inflammation, scarring, and it starts to develop adhesions, particularly in the pelvic cavity. Women between 30 and 40 get this a lot. They usually actually do the D&C in order to relieve some of those symptoms of endometriosis. They don't really know what causes it, but it's usually a dull cramping pain, pain during intercourse, and again, abnormal uterine bleeding, okay? So it's not, usually they find out that the patient's got endometriosis when they're doing infertility testing. That's usually when they find out when that happens. Ectopic pregnancy, this guy is trouble. Pain, the lower abdominal pain, sharp, severe, going up behind the shoulder blade, okay? That's like the dead giveaway, okay? Later, missed menstrual periods, vaginal bleeding is present. If this thing ruptures on you guys, remember, the early stages, it's not going to be a problem. But as the fetus starts to grow, the fallopian tube is not made to do this. It will not stretch past a certain point. If it tears, it's going to start leaking things all in the abdominal cavity, extreme pain, and it can cause the patient to die. Okay? The way that we fix this is we get them to the hospital immediately. IVs, again, make sure you get the patient comfortable. And again, it's a surgical emergency. It has to be cleared out by the surgeon. So get them to some place where they can actually perform surgery. Non-traumatic vaginal bleeding, very rarely do we see it. Menorrhagia, the excessive menstrual flow. Again, any type of hemorrhage that we can't really explain, we got to be ready for impending shock. And I will tell you that usually your non-traumatic vaginal bleeds, they can be dark red, but a lot of the ones that I've seen is a more brighter red color. It's definitely brighter than a menses episode. Usually you get a lot of cramping with this, passage with clots and tissues. And again, it's usually it happens because of abortion. And of course, this can be an emotional wreck for the patient, especially if they're trying to get pregnant. So please keep this in mind. It's not going to be a fun time for them. Uterine fibroids can also, they're non-cancerous tumors, but they'll get a lot of vaginal bleeding, heavy periods. They'll get a lot of abdominal fullness and a lot of pain during intercourse. Okay. And I've seen uterine fibroids where it actually fills up the entire uterus. So, again, double check these, ask these questions when we're dealing with with your older patients, your 30 to 40-year-old GYN patients. Again, absorb the blood flow. We don't pack the vagina. O2 therapy is needed, IV as needed, guided by the patient's condition. Okay? If we got trauma to the area, again, and actually the biggest one, and I've seen a lot of these actually, is your straddle injuries, okay? And this is due to, again, we're in the horse capital of the world. We get a lot of these, okay? So, again, the vaginal injuries usually are lacerations due to sexual assault as well. So these are a lot of the areas where we're getting this. And yes, by the way, the ladies, if they get punched in that area, it hurts, okay? So, again, the foreign bodies, again, if they get this inserted into the vagina, I've seen a lot of really bad self-abortion cases go really horribly wrong. And then the lacerations following childbirth. By the way, most of these have to be repaired surgically, usually, if they've torn something that they should not have. Again, usually direct pressure, if it's in the external genitalia, it might be the only time I would say you apply there. If it's internally, we don't usually apply direct pressure. Again, don't pack the vagina, don't pack the vagina, don't pack the vagina. Any questions? All right. 700,000 assaults every year from sexual assault. And unfortunately, I think that number is, why I would say, even underestimated, okay? Acquaintance rate, usually they know the person that did this. Sexual assault, guys, it's a crime of violence. It is not a passion crime, okay? The people that lose control and they try to achieve sexual satisfaction, I don't understand it, but people do it. And again, it's any sex without the consent, okay? And long and short, again, we have to usually go there and pick up the pieces at this point. Rape is defined as a penetration of the vagina or rectum of an unwilling female or the rectum of an unwilling male. Or again, sexual assaults can include oral genital sex, by the way. So what do? Again, emotional is probably going to be your biggest things. Guys, leave the stuff alone for evidence, okay? Maintain objectivity. You don't ask questions about specific details of the assault, but we do need to know what happened to the patient, okay? So, again, if it has something to do related to the care, and we can get that to find out what potential injuries they have, but walk a gentle, like you're walking on rice paper. Really gentle on that one, okay? And do not inquire about the patient's sexual practices. Not your job. Don't know, don't care, pick one, okay? Again, confine all the questions to the physical injuries. Approach calm and professionally. Try to alleviate any fear or anxiety, okay? And if they are patients incompletely dressed, cover them up, okay? Respect their modesty. Yes, you can cover them without destroying evidence, okay? If you use it, by the way, the covering goes with them, all right? If you're going to do something to a sexual assault patient, make sure that you explain everything you're going to do before you do it. Avoid touching the patient other than take vital signs or or perform treatments that you absolutely need to do. And we don't examine the genitalia unless life-threatening hemorrhage is there, okay? The patient may have been drugged. Psychological and emotional support is probably the number one thing that you can do, okay? If the patient is female, allow them to be cared for by an EMT or female that is, if available. Whatever makes that patient comfortable, okay? Whatever makes them comfortable, all right? Preserve the physical evidence. We want to make sure that we get plenty of evidence to put these scumbags away, okay? Consider the patient it's a crime scene and handle them as if they are a crime scene, all right? If you must remove clothing, you need to bag separately each item, and you want to bag them and close them and seal them and make sure that you maintain a custody of them, okay? We don't cut holes through tears of clothing if we can absolutely possibly not do so. Again, if you should place bloody articles in a brown paper bag. Do not examine the peritoneal area unless you absolutely have to. Again, if the assault took place within an hour of the bleeding, put absorbent pads in there to help collect the evidence. Yeah, that's right. We can collect evidence off of these little. Hopefully, we can catch these little bad guys. Okay. Again, you make sure that if you use a sheet or blanket, remember that will be turned over for evidence. Okay. We don't allow them to change clothes, bathe, douche, anything like that, because again, preserve the evidence. Don't allow them to comb their hair, brush their teeth. None of that, because again, they're going to do all of these things as part of the rape kit. Do not clean wounds, and if at all possible, okay? Again, remember, you're destroying evidence by doing so. State the patient's remarks accurately. You're going to need, I would actually use direct quotes, okay? Make sure that you objectively state your findings. You're probably going to go to court on this one, especially if we know who the scumbag is that did this. Yeah, we want to make sure that we want to make sure that we do everything possible so that these guys can't get cleared of the charges through a technicality. Okay. Do not include your opinion whether there was a rape that occurred. Objective, just the facts. All right, that's the end of this chapter. And again, make sure that you study these GYN emergencies. I was kind of surprised on my test how many that we actually had. So keep that in mind as you keep going through, okay? Make sure that you got a good grasp on these different medical emergencies, and make sure that you've read your book on this. I'll see you guys on the next one.